Thank you, Patrick, and thank you everyone for turning up, and thank you for the invite. It's always a great pleasure to be able to speak to people at the sharp end of Parkinson's disease. I think researchers often have a habit of seeing things a little bit in the abstract, and it's very, very nice to be able to talk to people and talk about their experiences of Parkinson's and how actually we can make a real impact on it. I guess this talk is a talk about genetics, but I guess it's trying to be quite a practical talk, in that I think that across medicine and across the news and certainly across the field of Parkinson's, there's an awful lot of talk about genes and how they impact on diseases like Parkinson's, and also how they're going to impact on how we treat these diseases in future. But it's all a bit abstract, really. It doesn't really mean anything in terms of meaningful drugs and treatments for these diseases. And I hope what I'm going to show is how we think that in terms of this particular gene called GBA, that we might be sort of one of the sort of prototypes of how these discoveries that have been made in the laboratory over the last few years might translate into something meaningful and something palpable, and actually some improvement in the lives of people who have Parkinson's disease. So Patrick's gone over the sort of history of Parkinson's disease, so I won't dwell on it too much, but it's been about 20 years since this Italian family who developed Parkinson's generation on generation were discovered. And why that was so important for the field really was it was the first indication that Parkinson's was a disease in which your genes played a very important part. When I was at medical school, indeed, which in fact was not that long ago, it was still being taught that Parkinson's was what's called your archetypal sporadic disease. So it's a disease that there was no inheritance with it at all. And this family and this discovery really focused everyone's minds to realize that that actually wasn't the case. And what was very interesting about it is that they discovered that mutations in this gene called alpha-synuclein seem to cause people to develop Parkinson's in a way that from generation to generation it was passed on. Almost 100% certainty that somebody in the next generation would get Parkinson's. And this caused a huge amount of excitement, not least because pretty much straight after that, it was discovered that this gene, alpha-synuclein, also was responsible for producing this thing called a protein, which was what was found in the brains of people who have Parkinson's disease. So in the brains of people who have Parkinson's, you get these things called Lewy Bodies. And actually it was found that alpha-synuclein was the principal component of these areas of the brain. And obviously it was a big finding because the discovery that actually in a family who generation against generation had something wrong with this substance called alpha-synuclein, and that actually almost every single person who developed Parkinson's disease has deposits of this alpha-synuclein in their brain, got people's minds whirring. And there was a great deal of excitement at this point, but unfortunately it was slightly short-lived because a lot of people thought, well, this is going to be the key, we've cracked it. Everyone who has Parkinson's is going to have mutations in this gene. But that just didn't turn out to be the case. And actually in retrospect, that makes a lot of sense because people with Parkinson's don't pass it on from generation to generation to generation. It's a lot more subtle than that. And so actually in retrospect, it made a lot of sense that it wasn't going to be directly problems with this gene alpha-synuclein that seemed, and specifically these kind of mutations, that were the key to getting to the bottom of Parkinson's disease and ultimately how you treat it. But what it did focus people's minds on was this, and it was the fact that actually genetics played a really important part in Parkinson's disease. And I won't bore you too much with what this graph shows, except just to focus on the bit in red. And what that shows is that if you take all the studies that have looked at the risk factors that contribute to people getting Parkinson's disease, by far and away the most important is having a family member who has Parkinson's disease. So your risk of having Parkinson's disease increases about 4-fold if you have somebody in your bloodline who has Parkinson's disease as well. Which of course implies as well that genetics plays a really, really important role in how Parkinson's develops. So moving to a slight tangent, it got people thinking about genetics. And around about the same time, a group of doctors called hematologists, so these are doctors who typically are involved with treating disorders of the blood, noticed something very interesting. And what they noticed is that amongst the patients who had this a very rare and slightly esoteric condition called Gaucher disease, that amongst these patients there seemed to be a much higher incidence of people getting Parkinson's. And not only that, but there seemed to be a much higher incidence of people in their immediate family developing Parkinson's. And why, of course, this was interesting was that this implied that there was a gene involved. And actually, in fact, it turned out to be the case, that in fact, this gene, called glucocerebrosidase, but I'll call it GBA for short, because glucocerebrosidase is a bit of a tongue twister, this gene did in fact seem to play a very, very important role in Parkinson's disease. But what was really interesting about it was this, that unlike in this Italian family, where generation upon generation upon generation, you almost one or two, or maybe all of those generations were seen to be getting Parkinson's disease, it was a lot more subtle in this case. So if you take 100 people who carry a GBA mutation, only between about 5 or about 30, depending on which study you read, will go on to develop Parkinson's. And actually, the reality of it is probably that it's much closer to the 5 kind of figure. So only around a small proportion of people who have this gene go on to develop Parkinson's. And in fact, you are far more likely not to develop Parkinson's if you carry this gene than you are to develop Parkinson's. And why that's very interesting is that it has a lot more relevance to how Parkinson's behaves in real life. We know that if you have a family history of Parkinson's, you're more likely to develop Parkinson's, but we know that actually it's not a case that if you have Parkinson's in your family, that you're more likely to develop it generation after generation after generation. And actually, what's even more interesting about GBA is that it is common. It's actually, in terms of in gene terms, very, very common. So in a country like the UK, if you were to genotype 100 Parkinson's patients in pretty much any part of the country, about 5% of them would carry a GBA mutation. If you go to places like Israel, where they have a large proportion of Ashkenazi Jews who seem to have a much higher level of these mutations within the population, it goes up to about 20%. So these are really, really big numbers, and the kind of numbers that actually start making a difference in terms of, the Parkinson's population as a whole. And the reason why this is important is, of course, as you'll have heard, I'm sure, time and time again today, is that once you've got a gene, you have a direct link into how it causes Parkinson's disease. And if you do work in the laboratory, you can work out piece by piece what that process is, how it happens, and then you can design drugs to try and stop that happening. And the end result is hopefully that you can stop the development of Parkinson's disease before it happens. And somebody who has a genetic predisposition like GBA to Parkinson's presents a very good opportunity to intervene in this way. So our group and groups like ourselves started getting to work. And what was very, very useful was the fact that actually, because the hematologist knew a lot about this gene before, there was about 20 years of research which had happened already, which meant that we had a 20-year head start on pretty much anyone else looking into genes causing Parkinson's disease. And that's been incredibly helpful. And it turns out that something very interesting happens. So GBA is related to alpha-synuclein. Now remember alpha-synuclein, that Italian family who had Parkinson's generation upon generation upon generation, and the substance that's found in the brains of people with Parkinson's disease? Well, there's an interrelation between those two things. And it seems that if you reduce the activity of GBA or reduce the amount of it, so reduce how much is present, then actually the amount of alpha-synuclein in the brain increases. The amount of alpha-synuclein increases. Conversely, if you increase the amount of GBA and increase the activity of GBA, then the amount of alpha-synuclein decreases. And of course, this is very, very interesting because it implies that you can directly control the amount of a substance that seems to be the principal component of the brain changes that are present in people who have Parkinson's disease. So we wanted to understand a little bit more about what exactly is going on. And I'm not going to go into too much of the science, but the bottom line is this, and I'm going to use an analogy, if I may, that GBA is what's called a lysosomal hydrolase. It's an enzyme that sits within an area of the cell which is kind of like a dustbin or a waste disposal unit. Do you remember waste disposal units? They were very big in the 90s. Everyone had them. They always broke down. But the idea was that you got all your vegetables and your rind and stuff, and you chucked it in there, and it made a sort of whirring noise, and then it sort of disappeared. And it's useful to think of GBA in that kind of context. It's one of these substances that basically gets rid of a lot of the waste products within the cell. But and so that was very, very interesting. Oh, excuse me, we've had that one already. But what's even more interesting is that it seems that alpha-synuclein, the substance which is found in the brains of people who develop Parkinson's disease, seems in some way to be broken down by this protein called GBA. But even more interestingly, if you have a deficiency in that, as is caused by people who have a mutation in GBA, or if in the laboratory you alter it in a way that stops it working properly, then actually the alpha-synuclein has nowhere to go and it just starts building up. But if you can do something which will stop that happening, so if you can reactivate GBA in some way, then actually you seem to be able to get rid of the alpha-synuclein and in the process, hopefully, we hope, stop the changes that lead to Parkinson's disease. So this was all very good, and this was very exciting work done in our lab and other people's labs in the laboratory. But the question was, then how do we get that to a point where it actually has some relevance to people who have Parkinson's disease? And basically the search was on for a substance that we could use to try and increase the activity, to try and increase the ability of GBA to get rid of alpha-synuclein. And so what we did, and again this wasn't us who did it, it was a group in America, they took a library of about 10,000 different drugs, and one by one they added them to this substance GBA. And they looked to see whether there was an increase or a decrease in the activity. Some it stayed the same, some it went down, and then in a few cases it went up. And remember, this is important because if it goes up, then correspondingly the amount of alpha-synuclein seems to go down. So the champagne corks were out, and actually what was even better about it was that this was a drug called Ambroxol. Now we don't know very much about Ambroxol here, but actually it's a very commonly used drug across Europe, especially in Germany and places like the Czech Republic, and it's a cough syrup. And what's even more better about it is that it's off patent, so it's very, very cheap, and it has a very, very good safety record. It's been used safely in clinical practice for about 50 years, which is fantastic news because it means that a lot of the very initial work looking at a drug to try and make sure it's safe has already been done. And so what we did in our laboratory is we did some experiments in the lab where we basically took some cells which carried the GBA mutation, so some cells where there was a reduction in its activity and an increase in alpha-synuclein, and we added Ambroxol to them. And what we found is that not only did the activity of the GBA go up, but the amount of alpha-synuclein in the cells went down, which was very, very interesting. And made us think that this is a drug that potentially, if we gave it to people with Parkinson's, might be able to slow down the progression of Parkinson's disease. And maybe if we gave it before the worst features had happened, we might be able to stop it happening altogether. And so we embarked we decided to embark on a clinical trial, so a drug trial of this drug, to see if we could get it to see if we were able to replicate these changes we'd made in the laboratory in a human. And we talked I think a few people have talked a little bit about the way clinical trials work. So you have three types of clinical trial. You have what's called a phase 1 trial, which is all the sort of basic laboratory work to make sure it's safe. And as I mentioned, because this drug is already established, we don't really need to do so much of that. Then you have a phase 2 2 trial, and that basically is what's called a proof of principle trial. That's to show that actually this drug can work in a human context and is able to do the things that it does in the laboratory. And this is what we're about to embark on, and we almost have ethical approval to start doing. And we want to show 3 things. The first thing we want to show is that if we give this drug to people who have Parkinson's disease, that it's safe, that they can tolerate it and it doesn't do anything, and specifically that it doesn't do anything bad to their Parkinson's symptoms. The second thing we want to do, well, we already know that if we give people ambroxol, that we are able to see these changes in the activity of GBA in the blood, but we're not sure if we can do that in the brain. We're not sure if we can actually get this drug into the brain to do the same thing in the brain. And of course that's very important, because if it doesn't reach the brain, then it's not going to be able to affect the cells that ultimately go on to cause Parkinson's disease. And the third thing is, if we get it into the brain, can we be sure that it actually binds to it, that it actually gets there and it's able to actually do the things that we want it to do? And so with these in mind, we needed to look for a way that we could try and assess these things in a safe way. Now, the most obvious way would be to take a brain sample from somebody who we give the drug to and to look what happens. But of course, you can't do that. You can't take a biopsy of somebody's brain. But what we can do is the next best thing. So around the brain, you have this substance called cerebrospinal fluid. And it's basically the sort of it's kind of the blood of the central nervous system, if you like. It flows around it, it gives nutrients to the brain. But what's also very good about it is that you can take a very small needle and you can take a sample of it from the lower back. And so what we were able to do is basically have a window, if you like, onto what's going on around the brain, and specifically to answer those 3 questions that I was talking about earlier. And so this is what we have decided to do. So we have designed a trial, what's called a phase 2 trial. It's called Ambroxol and the Modification of Parkinson's Disease, or AIMPD for short. And basically, this is a trial to answer those 3 questions that we were asking before. Does it get to the brain? Does it bind to GBA once it gets to the brain? And is it safe and is it tolerable in patients who have Parkinson's disease? So the design of the trial is this. We're going to take 20 patients, 20 of whom have Parkinson's caused by the GBA mutation, and 10 of whom have Parkinson's caused by the GBA mutation, and 10 of whom who actually just have Parkinson's which isn't caused by a genetic mutation. And the reason for that is, and I won't go into too much detail, but there seems to be evidence that some of the mechanisms we're talking about in Parkinson's caused by this mutation are directly relevant to people who have Parkinson's disease in general. And what we're going to do is we're going to give them, starting with a very low dose, escalating over the course of 6 months, ambroxol by mouth. And then we're going to take some samples of the cerebrospinal fluid before they've taken the ambroxol, after 6 months of taking the ambroxol, and then after 3 months when they've stopped taking the ambroxol. And what we're going to look for is see whether we're able to show that the ambroxol has reached the brain, whether it's interacting with the GBA protein, and also whether it's safe and tolerable to people who have Parkinson's disease, and whether they're able to take this dose of ambroxol for this kind of length of time. And what do we hope to achieve from this? Well, as I mentioned, what's very good about having a drug that's been around for 50 years is that actually a lot of the phase 1 work, a lot of the early laboratory work that has to be done to make sure a drug is safe has already been done on this drug. The phase 2 trial, AIMPD, which we're just about to start, will hopefully prove that we're able to get it into the brain and it's able to do the kind of things we see in the laboratory within the brain itself. And then we hope that the step to follow, and within the next 5 years, will be a much larger trial, a phase 3 trial, a trial which is looking to prove that the drug is actually able to prevent the onset of Parkinson's disease, which is, of course, a big unanswered question, because although we have all this lovely evidence from the laboratory, we need to show in people who are developing Parkinson's or have Parkinson's disease that we can stop it happening. So I've talked a little bit about how GBA mutations contribute to Parkinson's disease, how we think GBA causes Parkinson's, and then about strategies that we've pursued in collaboration and in conjunction with other groups around the world to prevent or to try and give drugs to prevent Parkinson's caused by GBA. And then I've talked about our compound, which is called ambroxol, which is going to, and a clinical trial which is going to start in the next few months called AIM-PD. And as I say, the intent of all this is in the next 5 years to have a phase 3 trial trying to test the efficacy, to test whether we can actually prevent Parkinson's in real patients. So thank you very much, and thank you very much to all our funders.
And we have time for a couple of questions if anybody has one. Yes.
These GBA mutations, is it, I don't know how many mutations there are, but is it something that shows with a consistency in the manifestation of the symptoms?
It's a very good question, and there are about 300 GBA mutations that cause Gaucher disease. There's 2 which are very common. They definitely do cause Parkinson's disease, although very interestingly, one of them, if you have it, you're about 6 times more likely to develop Parkinson's. If you have the other one, you're about 3 times more likely. There are other mutations which are very, very common, but seem to only marginally increase your chances of having Parkinson's disease. So you're about 1.5, 1.3, 1.2 times. And it's a very, very good question. And I haven't really talked about it here, but we're based in other studies. We're looking to try and categorize on the basis of individual mutations what the risk of Parkinson's is, because obviously that will be very important in trying to identify who are the people at highest risk of developing Parkinson's, so we can get to them early and hopefully give them drugs like ambroxol or potentially others which will stop it happening. So yeah, great question. Well, the issue is numbers. So about 50% of people who have a GBA mutation carry these 2 main mutations, and then the other 50% is the remaining 298. So actually getting numbers together to be able to observe that is difficult, but we have a cohort of about 100 patients who we follow up every 2 years looking at this. We're hoping to drastically expand that in the next few years. There's a study called Rhapsody, which is, again, also just about to start recruiting. But to answer that question is going to take a few years, I'm afraid.
Just to add in a little bit on that, there's a lot of work being done funded by the Michael J. Fox Foundation, where they're working with groups like the group at the Royal Free and the UCL, but also groups across the world. So linking up researchers in Britain with researchers in Israel, North Africa, and in America to try and get those numbers, so that you're following big cohorts of patients with different types of genetic Parkinson's, try and understand exactly those kind of questions. So there's really an international effort that's going on in that area, which I think is going to be very informative.
Is there a similarity in that Italian family? That, they've got this long hereditary. I know, like with Huntington's, it typically starts at about the same age as the parents, and it's very similar in terms of symptoms. Is it the same? So I think,
you might have the Contersi, so the Italian family with synuclein mutations, have a slightly, on average, an earlier onset than GBA mutation carriers, I think, and tend to have more cognitive alterations, so changes that are more like dementia. So there are differences between the genetic types. I don't know, Stephen, you probably know more about this.
No, not at all, not at all. I mean, I think the key point is the age of onset. I mean, clearly the fact that it goes from generation to generation, it starts earlier, means that this is a more powerful gene, and that whatever's going on with them is whatever is the process in the brain, and it's not 100% been worked out, but we have a good idea what's going on, is much, much more severe than other genetic mutations, and also people with Parkinson's in general. I think the key is, as I said, is that actually, although these are very informative, these mutations, because they give us really nice models to work with in the lab, actually the slightly weaker ones, the ones which have a little bit more relevance to people in Parkinson's in general, are the ones where the big money is going to be. But actually, it takes time and a lot of money to answer these questions, because you need a lot more people to do it, really.
Sounds a great story. Should I be betting my life savings on ambroxol?
Well, I wouldn't do that because there's not very much money in it because it's not it's not paid. I don't know is the answer. I mean, we wouldn't be doing this if we didn't believe that there was something in this. We're very optimistic about it, and a lot of other people are too. I don't think this will be the whole story. I mean, I think if you want my opinion for what it's worth, I suspect the way that this is going to go is that you're going to have individual treatments that are tailored to individual patients. So it's going to become very sort of profiled in terms of, a patient with, a LRRK2 mutation or a GBA mutation, and it's going to be, maybe a combination of those sorts of things put together. So I don't think it's going to be the whole story, but I think it's very, very promising, and as promising as anything else that's going on at the moment, certainly.
Yes, can I ask you, has anyone looked at the various parameters, comparing them with non-Jews?
So they have different mutations. So there are 5 mutations that are very, very common amongst Ashkenazi Jews that are, to varying degrees, less or more common than the general that are less common in the general population. I mean, the effect is A, that they have certain mutations which are more common, and B, there are just a lot more mutations amongst them. But there's not really a clear differentiation, it's just the fact that they have more mutations, really. There's nothing special about them except that they make a very good group for us to recruit from because it's a lot easier to get GBA carriers, basically. So but there's not really a distinction between them just on the basis of their ethnicity, I think.
Excellent. Well, thank you very much, Steve.
Thank you.